we should think about getting started here. I'm not going to make a big introduction because it's the one, the only. Steve Lewis is going to talk to us today, and take it away.
Thank you. I have to work out now how to. Okay, just give me a minute.
There you go.
Everybody got it?
Yep.
Thanks everyone, and I appreciate the opportunity of speaking today. Before I get started, a lot of the work that I'm going to present is from Dr. E.C. Shea and Dr. Wanashet-Zanibi, so I'd like to give them full credit. We're going to talk a little bit today about the lumbar sympathetic chain, which contains, as you can, I didn't do anything. Let's give it another try. Okay. So I'll talk today a little bit about the lumbar sympathetic chains, which are accessible in the groin area of the legs of all mammals. I'm going to sort of present a little bit of information about the multiplicity of effects that the lumbar efferents and afferents do in terms of cardiorespiratory behavior. And it would make sense, especially for the afferents, that they're in the legs, and they would probably subserve responses that are related to exercise and escape, the flight and fright response. So electrical stimulation of the lumbar chain elicits pronounced changes in ipsilateral, hindlimb, blood flow that should be, via activation of efferent, neurogenic, vasodilator, and vasoconstrictor nerves, which I'll detail a little bit. But when you stimulate the afferent fibers in the lumbar sympathetic chains, you get a pronounced vasodilation in the contralateral hind limb, vasodilation in the ipsilateral and contralateral brachial beds, the forelegs of rats, increased blood flow in the brainstem, a reduction in airway pressure, and increases in frequency of breathing, tidal volume, and ventilation. Now you can imagine all of those things would be pretty necessary if you were exercising or trying to escape from Bob Kirsch when he was angry at you. So it's pretty evident that the LSC afferents have a really remarkable pattern of effects. Now, if you're interested, we can get to the part where what's really interesting to us is that various disease states have an impairment of endothelium-dependent vasodilation, for example, in type 1, type 2 diabetes, in hypertension. But for some reason or other, the neurogenic vasodilator systems and vasoconstrictor systems for that in addition, aren't affected by the disease processes. And we think it's because, of course, they're sort of embedded in specialized nests that might protect them from all the disease processes that the endothelium, which is exposed to the blood, gets. So you can see, therefore, you can get, despite the loss of endothelium-dependent vasodilation, when you stimulate the nerves, you get a pronounced vasodilation in type 1 and type 2 diabetic rats, pronounced vasodilation in the hind limb beds of spontaneously hypertensive rats. Now, we won't have time to discuss this, but this has been part of a process that we're really becoming seriously interested in, is that if you stimulate lumbar sympathetic chain afferents, it overcomes fentanyl-induced respiratory depression by, we think, by the spinal cord, where it drives cervical sympathetic chain dependent input to the carotid bodies, and also directly centrally mediated increase in ventilatory drive via direct input to the commissural nucleus tractus solitarius and pre-Botzinger complex. So we can get it with cervical sympathetic chain stimulation, and we can get it with just one lumbar sympathetic nerve stimulation. How I know stimulating these nerves can immediately reverse fentanyl-induced respiratory depression is a really good question, and something that we're working as hard as we can on. This is electrical stimulation of afferents and LSC elicit pronounced pain relief in humans suffering from a variety of pain states, loin hematuria, and also chest and upper neck pain, as well as from the legs, feet, as well as from the legs and the feet. So the anti-pain part of the lumbar sympathetic afferents, of course, would be part of this the process that allow you to escape a danger. I imagine if you're running and you step on glass or a nail or something, that the pain won't stop you. You won't feel it to sort of maximize your ability to escape a threat. This is done by Erica Woodrum, and it's a really beautiful set of complicated sort of connections. But I just want to point just a couple of simple things out. We're going to talk a little bit about the direct post-ganglionic innervation to blood vessels, release norepinephrine and NPY to vasoconstrict, and the SNOs, as we refer to them, S-nitrosothiols, nitric oxide-containing thiol compounds, which dilate the arteries. We're also going to talk a little substantially about the afferent system, whose dorsal root, whose cell bodies are in dorsal root ganglia. They project over and affect the activity of the preganglionic motor nerves, which are driving the postganglionic vasoconstrictor and vasodilator fibers, as well as making connections within the spinal cord and also direct projections up into key brain regions, such as the nucleus tractus solitarius. And other people have found them up in the thalamus. And I found a recent paper that suggests that it ends up in the medial prefrontal cortex, which is about like 15 miles to the left. So it's pretty extraordinary that an afferent fiber would project virtually the entire distance in the brain. So in terms of the hemodynamic effects, when you stimulate a single lumbar sympathetic chain, this is, you put a hook electrode on the nerves. These are pentabar. This is a pentobarbital anesthetized rat. We stimulate at various voltages with 20 hertz, 5 millisecond duration. And we're looking at heart rate, arterial pressure, mean arterial pressure, Hindlimb flow, ipsilateral to the electrode. So if it's on the left nerve, this would be flow in the left hindlimb, and the contralateral flow. So you can see that at 2 volts, you get a really pronounced increase in blood flow and active vasodilation in the ipsilateral leg, not much in the contralateral leg. Now, as you sweep up in the voltages, you can see that at 4 volts, you've reached the neural fulcrum that Jeff Ardell beautifully coined, when not much happens. There's a reactive hyperemia afterwards. But as you step up, you can see a frank fall in blood flow, which is a massive vasoconstriction. Contralaterally, all you see are direct increases in blood flow. So you can see that this is the beginning of evidence that we've got 2 types of nerves, efferent fibers mediating vasodilation, vasoconstriction in the ipsilateral bed, and then presumably an afferent-mediated increase in blood flow in the contralateral limb. So this is just to summarize. When you sweep through all the voltages, you get a pretty minor, but a measurable fall in blood pressure that eventually goes away And we're presuming that's because, of course, at the higher voltages, you're causing active vasoconstriction in a whole lot of beds, such as a hepatic bed and renal beds that we're not directly measuring. The flow in the ipsilateral leg goes up, and then as you move up the voltages, drops remarkably, whereas the flow in the contralateral bed goes up. So this translates to active changes in the Hindlimb vascular resistance. Mean arterial pressure divided by blood flow is vascular resistance. You can see that the ipsilateral and contralateral beds, they dilate up until about 3.5. The ipsilateral bed starts to vasoconstrict, whereas the contralateral bed just stays dilated with each particular stimulus. So just to reiterate, what happens when you stimulate the lumbar chain and you've actually transected the contralateral lumbar sympathetic chain, you see that you eliminate the vasodilation. So it's still there ipsilaterally, everything's working fine, but without the opposing lumbar chain, you don't see the vasodilation. So at least we know that we have to have the lumbar chain on the other side to mediate the fall in blood pressure, the fall in the vasodilation. Now, in terms of the potential mediators for the vasodilator nerves, we've published a bunch of stuff, and these are post-ganglionic sympathetic nerves, and you see that they stain intensely for nitric oxide synthase, which people use as an indicator to make nitric oxide, whereas we believe, of course, that they're actually making these nitrosothiol compounds, and I'll give you evidence of that in a second. You can see this is wrapped around a blood vessel. You see all these highly densely stained varicosities and the fibers that run in the smooth muscle, within the smooth muscle. And here's an interesting experiment. So this is, NO synthase stained fibers in the lumbar chain. And what we did here was we actually put an 8O silk ligation on a lumbar chain, and then stitched the rat up and came back a couple of days later and took the nerve out. And what you can see is a giant buildup of NO synthase at the point of the ligation, which is directed. We know that enzymes are transported down the trunk towards the peripheral terminal. So we take this as further evidence that the NO synthase is heading towards the nerve terminals where the vasodilator substances are going to be generated. The idea that we have is just that the vasodilator neurotransmitter is just like any neurotransmitter. It's synthesized and it's stored in vesicles that are subject to action potential mediated excitosis. So this is what happens when you give 2.5 volts 3 times in a row and 4.5 volts 3 times in a row in an animal that's just had nothing. There's a pentabarbital-anesthetized rats. There's some, there are 5 or so minutes in between each of these stimulations. When you've then administered the nitric oxide synthase inhibitor, L-nitroarginine methyl ester, and then wait about a half an hour, I think it is, I keep forgetting, roughly a half an hour. You then do the first 2.5 volt stimulation. You can see that there's no active vasodilation. Then you go up to the 4.5, and the first 4.5 looks about fine. But then as you keep doing the stimulus, you keep running, the response goes away. Now, this isn't a trick situation. If you inject nitric oxide or nitrosothiol or anything, they're still fully active. So this and other work we've done is suggesting that we're losing the response because these nitrosothiols can't be replenished. When you block NO synthase, you just can't make any more. So you're just spitting them out but not replacing them. And I'll skip over this, but this is just the recovery. So you can see that you get this big loss in flow and a big loss in the vasodilator response in the unnamed treated animals. So just to make sure that it's neurogenic, we use the neuronal nitric oxide synthase inhibitor 7-nitroindazole. And this is what the response looks like in a rat before you've given the nitroindazole. There are about five or six stimulations in there. I think this is stimulus 6 or 7. But in a vehicle-treated animal, you can see it's pretty much the same. And in one that's had the neuronal nitric oxide synthase inhibitor, there's a vasodilation, and that's what it is after the 7th one. So again, consistent with the idea, we're just depleting the neurotransmitter pools. Yeah, the summaries. Now, to get a little more direct evidence that these vasodilator fibers are actually releasing nitrosothiols, we went to a isolated hindlimb perfusion preparation where we could perfuse buffer through the hindlimb. It's still neurally intact. It's just separate via an extracorporeal system. It's separate from the rest of the body. And then you do your stimulation and collect buffer from the ipsilateral vascular system. And you can see that we're being able to measure 2 nitrosothiols, S-nitrosocysteine, and the decarboxylated version, S-nitrosocysteamine, in roughly the same amounts. And it takes, a little bit of time for the levels to get back to where they were. Most importantly, we also saw it in the contralateral limb. So when you stimulate the left, for example, you're also seeing it release on the right. And I forgot to include it, but on the contralateral side, if the lumbar chain is cut, of course, none of this happens. So we measured, looked for S-nitrosoglutathione, couldn't find it, S-nitroso, a bunch of other things, and couldn't find them. So it looks as though these 2 nitrosothiols are the primary candidates to be the neurogenic vasodilator. So, okay, we have a system. Does the body use it? So there's evidence out there that activation of baroreceptor afferent input to the brainstem recruits this neurogenic vasodilator system. Activation of carotid body chemoreceptor afferent input to the brainstem elicits an activation of this system. Direct microinjection of glutamate into the nucleus tractus solitarius, including commissural, should be 2 S's, and medial aspects of the NTS, causes an active increase in lumbar sympathetic vasodilator activity. Anteroventral region of the 3rd ventricle. Direct activation of neurons of the medial prefrontal cortex does it. And in a more general sense, activation of the fright and flight response for exposure to air jet stress causes a massive bilateral activation of this vasodilator system. So with all of that stuff's been published, I just thought that we might, we're now working on the upper airway and presenting some work that what happens when you occlude the upper airway. It's just basically a mild asphyxiate pressure on the larynx of the animal to close the airway. So mean arterial pressure doesn't do much until you let the occlusion go. Heart rate drops and the big upswing. This is sort of very characteristic of what happens. The important thing is to note here is that you get a dramatic, during the occlusion, you get a dramatic increase in lumbar sympathetic nerve activity. Thank you to Martin Munsell, and sympathetic nerve activity. Again, thank you to Martin Munsell. So the occlusion is directly activates the sympathetic nervous system. In terms of the mesenteric neural activity, mesenteric flow drops, and mesenteric resistance skyrockets because it's a vasoconstrictor influence. This is abolished by giving an alpha-1 adrenoceptor antagonist, prazosin, for example. In terms of hind limb flow, you'll see a big increase in hind limb flow that does not occur in a limb where the lumbar chain is being denervated. And that results in a dramatic vasodilation and drop in resistance in the innervated bed, but not in the denervated bed. So, taken together, it seems as though this system is up and running, no pun intended, and can be recruited by a variety of stimuli, central drive as well as peripheral drive. So another thing that you'd expect afferents from the legs to be able to do would be to influence your breathing. I mean, if you're running, you want the afferents to be at least either passive or promote minute ventilation. So this shows minute ventilation of freely moving rats where we've stimulated the lumbar chain, and there's a big, it's not big, but it's a substantial increase in minute ventilation that is dramatically diminished if you put the NMDA receptor antagonist kynurenate in the ipsilateral commissural NTS. So it goes from that. So obviously it's not abolished, but it's a strong indicator that the lumbar sympathetic afferents are directly or indirectly impinging into the nucleus tractus solitarius to sort of alter signaling such that the NMDA receptor process is activated. In this part of the NTS, the kynurenate had no effect on the hind limb vascular resistance. You have to move to another portion of the NTS, the medial NTS, and the situations are reversed. But nonetheless, the key thing is that you get a big increase in breathing when you stimulate the lumbar chain. Going to EC and Watershed's work, you can see that in terms of these are now urethane-anesthetized rats that I'm showing, the urethane-anesthetized rats for a reason. You get a big increase in breathing frequency, both expiratory frequency and inspiratory frequency, tidal volume, and you can tidal volume, inspiratory, expiratory, and So let's just stick with the tidal volume. I've actually put in the same slide in both. I didn't include minute ventilation. A couple of things are important. The tidal volume and the frequency go up, but you notice that they stay up for a substantial period of time. That stimulus, it's only for 10 seconds. So you can see that all of those seconds, and there are about 8 or something like that rats in this group. This is actually group data. So there's a profound input on tidal volume and frequency as a result of stimulating these afferents, even in a urethane anesthesia. And of course, it's incredibly dramatic in the freely moving rats. The other thing that you'd like to see happen, and again, thank you, Watersheds and EB for this, is that you'd like to open up the airways to ensure that you're, as you're running and breathing more heavily, that nothing is impeding the flow of air into your lungs. And as you can see with these two stimulation paradigms, you see a nice fall in upper airway pressure in these urethane-anesthetized rats. Just with respect to what else the afferents do, again, in these urethane-anesthetized rats, if you take these two stimulus paradigms, 5 Hertz, 20 Hertz, obviously the 0.5 and 5 millisecond, you see a nice reduction in mean arterial blood pressure that isn't associated with an active increase in flow. But of course, if you do your sums, that becomes a very nice reduction in vascular resistance. Okay, so as the pressure is falling, you would expect to see a fall in blood flow. The fact that it's not falling means it's actively dilating to take in more blood, and you can tell that by the active change in resistance. So, so this is the left lumbar chain, causes vasodilation in the right arm. So left leg causes an increase in blood flow in the right arm, so to speak. And the right stimulation also causes a change in the right arm as well. So it's apparent that these afferents, when they get into the spinal cord to affect blood flow in the forearms, that it's bilateral. It'll affect both. Now, of course, the ability of the lumbar afferents to do this tremendous increase in blood flow to the arms and hands would be of great therapeutic value to patients who have Raynaud syndrome, idiomatic decreases in flow because of various vascular diseases, and including type 1 and type 2 diabetes. So this particular thing, result that EC, Shea, and Weinerscheid have uncovered has got a lot of incredible potential. So finally, we'll just get into, aside from the slide I just showed you, can we stimulate the lumbar chain for good purposes therapeutically? So so basically we've got Sprague-Dawley rats conscious, Wistar-Kyoto rats conscious, both normotensive strains, and the spontaneously hypertensive rat, of which the WKY is the parent strain for. So again, 2 normotensive strains and a hypertensive strain. If you stimulate at 1, 2.55, and 10 hertz frequency of a lumbar chain, you get this nice frequency-dependent fall in blood pressure. You see falls in ipsilateral Hindlimb resistance, which is actually, they look, a lot bigger in the SHR, right? It's pretty dramatic. And nothing in the denervated bed. So this is, I should mention, this is, sorry, I got this wrong. This is when you stimulate the aortic depressor nerve. So you're stimulating baroreceptor afferents. These afferents go into the central nervous system and then elicit a whole lot of hemodynamic changes, including active neurogenic vasodilation. So there's nothing wrong with the system in the hypertensive rats. So when you just take one lumbar chain and stimulate it in these SHR, you can get, it's about 15% fall in blood pressure, not dramatic. Nice increases in flow and a beautiful reduction in Hindlimb resistance in the ipsilateral bed. So in terms of a therapy though, what if you're thinking about, hey, if we've got these magic electrodes that Neuralink are working on, that maybe we could, get a better reduction in blood pressure. So this is what happens when you do bilateral LSC. You can get down to 30% change, which makes them almost normotensive, increase in flow, and sorry, I'm presenting a seminar. Yeah, so sorry about that. So now, so it looks as though in terms of hypertension, you can maybe think of employing stimulating the lumbar chain afferents to lower blood pressure. The reason that you'd ask me, why not just put it on the aortic depressor nerve, the baroafferents? is that in humans, it's almost impossible to find. We work with Galvani here, and we did a bunch of human cadaver work, and it was almost impossible to identify the aortic depressor nerve in humans, whereas it was very, very easy to identify the lumbar chain. So this is a slightly different scenario now, where the central activation of the vasodilator system is impaired in a disease model, whereas the stimulation of the lumbar chain is not. So unilateral aortic depressor nerve, Baroafferent nerve stimulation is a markedly smaller reduction in hind limb resistance in type 1 diabetic animals. We make the animals type 1 diabetic by giving them an injection of streptozotocin and then waiting a few weeks until they're fully diabetic. So stimulation paradigm, you can see a small reduction in blood pressure. You don't get a lot of changes in flow at that level of stimulation, but of course, again, a big reduction in blood pressure with no change in flow translates to a big vasodilation and drop in hind limb resistance, which is really impaired in the diabetic animal. But if you actually stimulate the lumbar chain directly, and you get pretty much the same. I mean, technically the response is bigger at one point, but the point is that you're not getting any diminution of the changes in a streptozotocin rat compared to a vehicle rat. So you're getting a healthy big response by stimulating the lumbar chain. Now, again, why this is exciting is that we know that diabetics suffer from poor perfusion of their feet, poor perfusion of their arms and fingers, and that's a massive cause of their pathology. So this may represent an interesting way of actually, maintaining healthy blood flow in these disease patients. And so I've got people to thank the University of Iowa, at Galvani, Arun Sridhar, who have done a real lot to support this work. And in terms of grants, there's multiple triage applications to the NIH. And I'd like to thank Bob and Cheryl for giving us their support. And if anybody's ever interested in chasing this work up, there's a bunch of references that I could send them. What I forgot to mention was, again, I forgot to get the data together, but I just want to quickly show you minute ventilation, breathing, injection of fentanyl, which dramatically reduces their breathing. If you do not stimulate the cervical sympathetic chain in this instance, this is what the recovery looks like. If you stimulate the cervical sympathetic chain and the lumbar chain, this is what you get. You get this dramatic reversal. So I would love to actually sort of work on this a little bit as a strategy for overcoming opiate-induced respiratory depression. It's an interesting way forward. So thank you very much.
Thank you, Steve. I have a quick question. So how could you test this in people? Can you stimulate the sympathetic chain by the surface just to test it? Yeah, the answer is yes, Bob. I don't know the exact details yet. I'm part of the study, but I haven't worked out what the hell's going on yet. But Arun Sridhar is working with some colleagues in the UK for pain relief. So what they're doing is they're putting electrodes, pin electrodes, or they're just jabbing the lumbar chain, and they're doing pain studies, but they're also measuring blood flow and ventilation and a whole bunch of things in humans, and they're getting fantastic data. They're after the pain relief. So the pain studies, incidentally, everything we know about the lumbar chain and pain has been done in humans. There hasn't been a single appropriate rat study yet, which we're, obviously are going to try and work on. But yes,
And I'd love to be able to talk to to get together with Arun and sort of talk through exactly what they're doing. But so I can tell you that they're getting pain relief. It's been published previously on loin hematuria syndrome and on shoulder X syndrome. I've forgotten what the shoulder syndrome is called. So by stimulating one lumbar chain causes sustained pain relief. As part of the ongoing studies, they're also finding out the tidal volume is going up 10, 15%. They're not overstimulating the nerves. Upper airway resistance is dropping, and they're getting changes in blood flow in the arms and in the legs. So the humans might be a good model for the rat.
I'm just curious, though. How far do you know how far from the surface this chain is?
No, I don't. Like I said, it'll be something that we should talk with Arun about. He's willing to tell us everything. I'm just not. I haven't been in contact with him for a few weeks, so they just got the study started. So I don't know, but I know from the published work that these were that would make an incision, put the electrode on the nerve, and stimulate it for like 2 hours, and then remove it, and the patients would get long-lasting pain relief from that one 2-hour episode. And I can certainly send you the papers, and I'll look into it. But I know the study with Galvani. With Arun's company, Arthur Industries, they're looking at it being a permanent indwelling electrode, but I don't know any more details. And we should he'll talk to us for sure.
Yeah, I just looked up quickly. Those run right along the spinal column there. So,
oh yeah, it's incredibly easy to find. I mean, and they're big, bulbous, post-ganglionic networks.
My guess is you'd get a lot of the spinal roots if you tried to stimulate it sufficiently from the surface. They're small axons, aren't they?
Yes, they are. They are.
Yeah.
Yeah. In comparison to what the more indwelling ones in the neck and in the body, for sure.
Yeah.
But apparently it's all doable, Bob. They're having they're getting really excited about what they're doing. As always, I'm a little bit confused about what electrode technology would be appropriate for that for humans. But you tell me that you've got indwelling electrodes that last for a long time, right?
Yeah, I'd have to look at the size of both the trunk itself and the individual axons.
Yeah, and we've got that data down to the micron almost. As I said, we did the dissections here at Case with Steve Shomish. We set up, and the surgeons came and they had their specialized cameras and took photos, and they've got, everything is sort of measured, and all the branches and everything.
Okay.
And I'm hoping to get those pictures really soon with all the gradients, so we know exactly what size and what everything looks like. And I'd be happy to share that with you.
Yeah, the other thing to think about is intraoperative testing. People having surgeries in their back.
So we have 3 of those patients on the table that agreed to it. They were type 1 diabetics. And in all cases, in one case, the surgeon almost refused to remove the infected foot from the diabetic patients. Was when they stimulated the chain, they got a massive increase in blood flow in the foot. But then they had a consultation, said, well, look, what are we going to do about it? We don't have an electrode to implant that would, work. So that was incredibly. Arun called me about 4 o'clock in the morning, my time, to tell me that. They actually saw the surgeon basically had had a breakdown and said, well, where are these electrodes?
Sounds like an opportunity.
Yeah, the pain thing is driving this, Bob, because again, if I could remember the person's name, but he's a pain surgeon who started the lumbar chain stimulation work for pain, and of course this has given us the opportunity to piggyback and do all the other things that we would love to do. That is an opportunity.
Hi, Steve. Hi, this is Elias from Cleveland VA with pain management. So there is literature on peripheral vascular disease and even spinal cord stimulator for salvaging limbs for clinical limb ischemia. So this phenomenon of being able to modulate the sympathetic autonomic nervous system from the either spinal cord or sympathetic chain is well known. And actually what we do sometimes, we go at the L2, the sympathetic chain is anterior to the column. You cannot achieve it from laminectomy from the back, when you do laminectomy decompression. But many times we just go and do an L2 sympathetic block, and we can see significant, if the patient has reserve capacity in terms of improving vasodilation and improving oxygenation of the limb, we can do this with just an L2 sympathetic block with local anesthetic. So this is a very, very well-known phenomenon. The problem is there is nowhere where to stabilize the electrode to be able to achieve consistent stimulation of sympathetic chain. And actually you have to go fairly deep to go anterior on the spinal column to be able to achieve any kind of access to these ganglions, And the ganglions, they go up to L2. The sympathetic system is up to L2. It doesn't go much more below that.
Right, yeah. So the concept that we're working on, though, is to move up the chain where the afferents still mediate the ipsilateral vasodilation, the changes in brachial blood flow, and driving minute ventilation. So apparently, everything you said, of course, is absolutely correct. But if you move further up, you can actually still see dramatic. One of the patients, it was quite high, and they got pretty on the table. An anesthetized patient on the table got what they thought were great results. So, as always, it's accessibility and will the device stay where it needs to stay, as always.
One of the areas that you can achieve better modulation of actually the cardiorespiratory system is the upper part of thoracic spine. And we're trying to do that through intrathecal space, either with medication or even with electrical stimulation. We had some work done even with the Steve Shomich, shop down there with the sheep.
Right.
When we just put a catheter into intrathecal space and try to push very, very fast, a very, very small amount of local anesthetic and blocking the T1 to T4 sympathetic chain to be able to see what is the response. And you could see the response if you monitor the animal, the response on blood pressure and the heart rate. So it's quite clear that the T1 to T5 area of the sympathetic chain has very profound neuromodulatory effect on the cardiorespiratory effort.
Right. So that's my favorite part of the spinal cord, because and Paulina, who's on this call, I hope, still, is because the T1 to T4 contains all of the preganglionic motor flow out to the superior cervical ganglia, which control your cerebral blood flow. And I'd love to talk to you about this because we've got direct evidence that a loss of that system is responsible for the dramatic drops in vascular blood flow in the brain and ultimately vascular dementia.
Yeah.
So
and actually, we're just even right now, we're trying to, together with a colleague of mine at Hopkins, we're putting something together for stellate ganglion block for traumatic brain injury to take a look at the molecular signatures of changes on traumatic brain injury with a stellate ganglion block, which has most of the fibers from the upper thoracic spine too, from T1
right.
and T2.
So Paulina did a set of experiments where she took the superior cervical ganglia out of rats, and she sent the brain stems off to a company which does the proteomics, and we were able to virtually exactly replicate all of the proteomics that are associated with vascular dementia and Alzheimer's disease. And I'm not kidding. It was like frighteningly close, including the beginnings of all the tangles and everything. We measured the blood flow was drastically dropped. So this was only 4 days after we did the removal. It's clear from the literature, if you have injury in the spinal cord, anywhere in the spinal cord, that you will have a greater chance of developing vascular dementia. If you have a bona fide medically proven injury in T1 to T4, it's almost 80% of patients long-term will go on to develop some sort of vascular dementia. And we think that's related to damaging the input to the superior cervical ganglia and therefore, input to the cerebral vasculature. So it's an interesting story. I'd love to chat to you about it.
Yeah, great, anytime.
Any other comments or questions for Steve? It's pretty interesting stuff, Steve. I mean, when I think of the impact on, like you said, blood flow in diabetics and blood pressure regulation for anybody, really, it's really interesting stuff.
Yeah, and Bob, the more you dig into it, I've got a colleague in Germany who says that the Raynaud syndrome is the most underreported syndrome on the planet. He says probably anywhere between 15 and 20% of people have inappropriate blood flow to their fingers and feet, and it's responsible for all sorts of stuff. So being able to put some sort of electrode on to promote blood flow in your fingers and your feet, especially with diabetes, would seem to be like at least an interesting idea.
Yep. Okay. Anything else, folks?
I actually have a brief question. This is Robert Adams from UH Neurology. It's actually on the diabetic rats that didn't show response to electrical stimulation. Do you think that's more of a neurogenic process or a vasculopathic process? Do you think it's the vessels not responding to input due to the diabetes, or do you think it's actually the loss?
Right.
Of the
So
neurons?
well, I didn't explain it very well. Let's just go back to it very quickly. So this is when you stimulate the aortic depressor nerve, baroreceptor afferents, into the brain. And then you see in the diabetics, you get a much smaller response. If you micro-inject glutamate, the excitatory neurotransmitter, into the nucleus tractus solitarius of these rats, you also get a diminished response. So we think, whereas if you do the electrical stimulation of the chain, you get a completely normal response. So what we're trying to say is that in diabetes, diabetics, it's the central drive out to the system which is impaired. There's nothing wrong with the peripheral system per se. It's just, and we've also done spinal cord stimulation, and that's like dramatically impaired in diabetics. And I thought this was going to be a Nature Science paper, but people have published on this for 100 years. So it appears that the afferent processing part of the arm is greatly affected by diabetes, whereas the efferent motor part is not.
I see. Very interesting. Thanks.
I'm curious about some of your experimental technique. You say that respiratory frequency increases in the tidal. Oh, this is Fred Montague, by the way. Respiratory frequency and tidal volume increases, and then you say the upper airway pressure increases. Should that actually be upper airway resistance, or what is meant by upper airway pressure in that case?
No, the upper airway pressure drops. The upper airway pressure actually drops. And
what is upper airway pressure in that case? Because there's inspiration, expiration, mean airway pressure.
Yeah,
I'm not sure.
Absolutely. This was just a general graph. We use the double chamber head out plethysmography system to be measuring airway pressure, airway resistance, compliance. And the story is basically the same. And you get a pretty marked reduction in airway resistance, an increase in compliance, which results in a drop of upper airway pressure. I'd be happy to show you the data. We've got some beautiful data. This is from Dr. Shea's lab, and I've sort of stolen a slide to present with his permission, actually. But yeah.
Yeah, and I'm just curious how you measure minute ventilation in a freely moving rat. That's got to be a real.
No, it's very simple. We have what I call whole body plethysmography chambers. So the pressure and airway resistance data, the rats are placed into double plethysmography chambers. So they're awake, but they're constrained within the system. So that's where this data comes from, as you can see. The breathing comes from, you put freely moving rats into this plethysmography chamber. It's a round chamber that's actively recording the frequency, tidal volume, peak respiratory flows. And we have a really nice system, and so does EC downstairs. So it's very simple. And we can inject the animals, you can stimulate nerves, you can do, whatever you want, because they're all sorts of ports that, catheters and things can sort of come out of, and there are swivels, assemblies and things like that. So you can do your experiments.
So the plethysmography is the trick.
Yeah, it is. You'll have to ask Paulina Getzi. After about 10 years, you can be an expert too, right?
I got it.
Yeah, but that's free. We make the equipment freely available to anybody who wants to use it.
Okay, last call. Any more questions for Steve? Okay, well, thanks, Steve. That was really good. So I guess our next get together is Thursday. We have Phil Starr giving an MP seminar, and that is at what time? It is at
3 o'clock.
3 o'clock.
Yeah.
Okay.
Thank you, everyone.
All right. Everyone have a good evening.
Thanks. Bye.
See you soon.